Good evening, everyone. Thank you for taking the time to come out. The talk I was asked to give, as they said, was pain-free pain management or opioid-free pain management. And certainly I'll cover that. I'm also going to try to tell you a little bit more about what we do in our practice and kind of our approach with patients. In terms of disclosures, I don't have any relevant conflicts of interest or anything to disclose or anything like that in terms of drug companies or manufacturers or anything like that. This will be kind of an overview and outline of what I'm going to cover tonight. First, I'll go over a little bit about my background and education, go over some of the conditions and main conditions that we treat in our clinic. We're right upstairs here in Monadnock Orthopedics. Go over treatment options in kind of broad categories, and then as we go along, I'll kind of drill down in a little more detail within some of those treatment options. And as I said earlier, I was asked to specifically speak about opioids, so I'm going to go over some details about the role of opioids in acute pain, in chronic pain, and some of the pluses and minuses. Just go into a little bit more detail, and particularly as we talk about chronic pain, I think that's where opioids kind of run into a wall a little bit. You know, if you go into the ER and you have a broken ankle or you need major surgery, chances are they're going to, of the medications they give you, chances are some of those medications are going to be opioids, and that's not necessarily inappropriate. It can be very useful and beneficial in that setting. However, when we talk about pain that's been going on many months, many years, maybe decades, there are some features unique to opioids that sometimes make them less ideal in those situations. And then, as I mentioned, we're going to kind of focus a little bit more, and you'll notice it's going to cut out from time to time. It's some kind of system issue here, but we'll work with it. We're going to focus in quite a bit on spine pain, because that's really a lot of what we see in our practice. As I tell a lot of my patients, you know, if Toyota made the human body, there'd be a recall on the spine, right? It's just a problem-prone area. And whether we're talking about the neck, the mid-back, or the low back, there's many structures within those areas that can give you trouble. And so part of our approach when patients come to see us is trying to sort out of the 6 or 8 or more possibilities of things that could be causing pain in that area they're pointing to, what structure may that be, and then we can try to direct treatment towards that. So in terms of my background and education, I went to medical school in Des Moines, Iowa. And then I came back to New England and did my internal medicine year at UMass Memorial down in Worcester. I'm actually from Worcester, Massachusetts originally. And then I went back out to the Midwest and I did my residency and fellowship at the Mayo Clinic in Rochester, Minnesota, which after 4 years there, winters in New Hampshire kind of seemed like Palm Beach. I don't know if you've ever been to Minnesota in the winter. Unless you have a really good reason to be there, I don't necessarily recommend it. And then I've been here now for about 14 years. I started here in July of 2010, basically right when I got out of fellowship. And I don't know if any of you know Dr. Harrington, who works upstairs, who's been here even longer than me. He actually also trained at Mayo Clinic, Rochester, and that's kind of how I ended up here, actually. He and I met at a conference, sat down for a couple long meetings, and he twisted my arm, and before I knew it, I was here in Peterborough. And it's been great working with him and working in that group, and that's why I'm still here. I really enjoy practicing here. In terms of my clinical interests, as I mentioned earlier, spine pain is a huge part of our practice. Most of that is low back pain. There's certainly plenty of neck pain and mid-back pain that we see as well. It's a very, very common areas for people to have pain, and we end up seeing quite a bit of that. We also end up doing a lot of musculoskeletal care. I'm upstairs within an orthopedic practice, so oftentimes the orthopedic surgeons are sending me patients saying, hey, this person has shoulder pain. Either they've already had surgery and we don't think they need surgery. What else can you offer this person? Or it might be their hip or something like that. We also treat a lot of chronic pain in general, and that could be things like fibromyalgia, neuropathy, any different varieties of chronic pain we end up seeing as well. In addition to focusing on pain, I know sometimes patients, I think, get understandably annoyed when we're asking them to score their pain, because let's face it, a 7 for one person may be a completely different experience than a 7 for somebody else. And so we often want to talk to people about, well, what's your function? What are your goals? How's your quality of life? Because one person at a 7 may be relatively satisfied. Let's say we take someone from a 10 to a 7. For them, that may be good, and they feel like they can do what they need to do. For someone else, a 7 may be a major problem, and they can't go to the mailbox, they can't go to the store. And so we like to incorporate functional goals and talking to them about their quality of life in addition to just looking at those numbers. There's quite a few minimally invasive procedures that we offer. And as I'll mention later, it's often a matter, especially in the context of chronic pain, of combining several things that work and kind of stacking those up. Because chronic pain can be very difficult to treat. And it's relatively rare that you'll find one injection or one medication or one physical therapist or one chiropractor that in and of itself takes care of the whole problem. So if you can find, let's say, 4 different things that each help 10, 20, 30, 40%, and then you stack that all up, that can start becoming very meaningful for patients. And we also always like to think about the cost of care as well. So I had a patient today. Unfortunately, she's between jobs. She has this new spine pain. I had seen her several years earlier. Kind of a recurrence of the prior issue along with some new symptoms. And she says, I'm in a lot of pain, but I don't think I can afford an MRI. I don't even know if I can afford x-rays. What kind of medication options do you have that may be inexpensive? And so we're trying to factor that into care as well, because if you're feeling way better, but you're in a lot of debt, well, that's not necessarily an ideal situation. So we try to interact with patients too in terms of what's reasonable for them in terms of their resources, their insurance, et cetera. So as I mentioned earlier, we see a lot of low back pain, a lot of neck pain, neuropathy. We actually treat a fair amount of migraines as well. We usually do that in conjunction with the patient's neurologist, because often the neurologist is managing the medications, and there's a procedure that we've been doing, and I've been doing it all the way back from when I was doing my fellowship at Mayo, when we had the privilege of being able to work in their headache clinic as well, of doing Botox for migraines. A lot of people think of Botox as a cosmetic treatment, but Botox for migraines is probably one of the most effective things that I offer to patients. And I've had patients that had daily disabling migraines, you know, almost with no headache-free days in an entire month. And for some of those patients, getting Botox injections every 12 weeks either wiped out their headaches or, you know, cut them way down. We usually tell patients we'd like to see you get at least 50% relief, but we have some patients where it almost completely wipes them out, which is, you know, it's an amazing thing for a patient to go from basically being disabled at home with terrible migraine headaches to feeling basically headache-free. And sometimes we're combining that with other treatments as well. We treat a lot of arthritis pain, especially in conjunction with my orthopedic colleagues upstairs. Again, if there's a patient who's either not a surgical candidate or already had surgery and is still having discomfort, they'll often bring us in. Fibromyalgia, we tend to see a lot of that as well, and sometimes that's a diagnosis unto itself, and sometimes that's in combination. You know, a lot of patients that we see who have a diagnosis of fibromyalgia, I think sometimes get discouraged because when they go and see doctors, everything gets assigned to their fibromyalgia. And, you know, it's certainly possible to have other diagnoses in addition to fibromyalgia, and sometimes you have to treat those things separately for the best results. In the last year or two, we've been prescribing a lot of low-dose naltrexone for fibromyalgia, which is a very low-dose, safe medication. And we're very lucky here in Peterborough that there's a compounding pharmacy downtown that can make this medication for us, because this is not something you can get at CVS or Rite Aid or anything like that. A pharmacist has to be able to make this up and mix it up for patients. And similar to kind of Botox for migraines, we've had some real game-changing results with that. Again, not every patient, no patient is exactly the same. There's no singular holy grail for any given pain diagnoses, but we've had some patients do really well with that, in addition to the more typical FDA-approved prescription medications and things like that. So some of this I've already touched on. I think one of the most important things when patients come to see us is they get a thorough assessment. It's not uncommon that a patient will be sent to me for, let's say, a very specific injection. You know, one of my orthopedic colleagues may send them to me and say, I'd like you to do a hip joint injection for Mrs. Smith. And that's fine, we're happy to do that. But whenever patients come to see us, before we do any procedures or any treatment, we always want to assess them very thoroughly, see what's been done before, really critically evaluate that. For example, patients may have had spine injections done at Dartmouth or somewhere else a few years earlier, and they may tell us they either worked or didn't work. In addition to just looking at what we've done, we'll often request the pictures from the procedure and really try to dive deep to see, are those locations exactly what we would have liked to have seen? Is there anything we could optimize? And really try to leave no stone unturned, because as I mentioned earlier, it's often a matter of finding a few things that can help and kind of stacking those together. In terms of physical modalities, usually by the time patients have seen us, we might be the third, fourth, or fifth or more opinion. So a lot of times patients have already seen physical therapy, chiropractic, massage, etc. But similarly, we want to go into detail with them about what's been done to see if anything could be tweaked about anything that's already been done before. I think one area, among others, that we're very unique is that we do osteopathic manipulation. I don't think there's too many pain clinics that I'm aware of in New England where the physician is doing hands-on treatments with the patients in addition to medications and injections. So my medical degree, I'm a DO, not an MD, so the medical school I went to, we spent a lot of time doing hands-on work with patients. And osteopathic manipulation, for those of you who are familiar with chiropractic, has some similarities, although most osteopathic techniques are a bit gentler. So particularly in the chronic pain population, that tends to be tolerated really well by people. So I have some patients I'm treating into their 90s where we're doing hands-on treatment where, a more traditional kind of crunch and crack chiropractic may be uncomfortable for that kind of patient. In terms of medications, there's a wide variety of medications that we may prescribe or recommend. A lot of those are non-opioid medications, and we'll talk about those in a little bit. And sometimes we certainly have some patients that we're prescribing opioids to, although we usually want to make sure they've tried other things first rather than go into that as the first line, and we'll talk about why that may be in a couple minutes. We certainly do a lot of injections, and some of those are in the office. I brought the ultrasound machine down here. So that's a very handy tool that we can do injections in the office where we can see through the skin, through the muscles, the tendons, we can see the joints, and we can guide the needle exactly to where we want to go. That way, if the patient responds or doesn't respond, we know the needle got where we wanted it to go. And then that way, if they don't respond, we know it wasn't a technical issue. We know maybe we have the wrong diagnosis or we need to think about other things. And then there's quite a few procedures that I do in the operating room here. Some of those, there's anesthesia provided if needed, and a lot of them patients actually don't require anesthesia. We just reassure the patient, educate them, use a lot of skin numbing, and most patients really sail through them quite well. We already talked earlier about Botox. I don't think we really need to talk about that again. And sometimes we do a thorough evaluation and we decide we may not be the best person for that patient. Sometimes someone will see me with a new severe spine issue and I look at their MRI, and due to the nature of their anatomy, I feel they might need surgery more than they need an injection or a medication. And we do have a spine surgeon upstairs, Dr. Vacci. Some of you may have met him. It's great to have a spine surgeon right in the office, or if they need to go to Dartmouth or Boston, then we're going to make those referrals, or if someone needs to see rheumatology, et cetera. The other thing that I think is very important that we offer is continuity. So for a lot of patients, myself and my nurse practitioner, Sarah Neal, we're oftentimes like their second primary care physician. It's actually very uncommon for a patient that I'm working with that I see them just once or twice. It's much more common that I've seen them for years. And in fact, there's many patients where I got here in 2010 that I still see them now. And I see them on a regular basis, and we're always trying to fine-tune things as appropriate. So let's talk a little bit about opioids in particular. First of all, I think it's good to be aware that chronic pain is extremely common. So about 100 million Americans either have or have experienced chronic pain at some point. That's about 1/3 of the US population, which I think is a lot more than most people would expect. It's not uncommon, I think, for patients who have chronic pain to sometimes feel like they're relatively isolated in that experience. And they may be one of the few people experiencing that. And in reality, it's a very common issue. And about 25% of people who have experienced or are experiencing chronic pain are experiencing to a moderate to severe level. And then about 5 to 8 million Americans use opioids for long-term management. So why are opioids an issue? If opioids can be used for pain and we have so many people with chronic pain, then why don't we just give more opioids, right? Why is that not the solution? There are some unique qualities to opioid medications, and some of those qualities can be helpful, particularly in the setting of acute pain, but in the setting of chronic pain can become a bit of a problem. I think most people are generally familiar that opioids can be addictive. And what addiction means specifically is use despite harm. So that may mean that someone's taking it despite them having major side effects, despite them losing their job, losing their family, losing their financial situation, etc. There's other features of opioids that are useful to be aware of that are separate from addiction, something like dependence. When a lot of people hear the word dependence, I think they think of that as one and the same as addiction, and it's not. Dependence is actually a physiologic phenomenon that you don't necessarily have any control over. And that would be, let's say, I'm taking opioids for chronic pain, and I'm taking them at relatively high doses, and I'm doing that for months to years. If I were to go on vacation and lose my medication, I'm going to probably experience withdrawal symptoms, and that doesn't mean I'm addicted to that medication. That's a physiologic phenomenon of how my body's responding to the lack of that medication. The other feature, and this is probably the most important feature as to why opioids can be a problem for chronic pain, is tolerance. And what tolerance means is the same dose that worked well the first week or two you were taking that medication, several weeks or several months or several years later is no longer having much effect or is having less effect. And that is a very common feature of opioids, and that's a keystone reason why opioids can be a problem for chronic pain. Because if your pain's going to be there for years, but this medication's only going to work well for you for days to weeks, you can see how that mismatch could be a problem. We've already touched, I think, a bit on acute and chronic use, and we'll talk a little bit about acute and chronic pain here in just a minute. There's also some important side effects of opioids that can be dangerous. So opioids, in addition to affecting pain receptors, can affect other areas of the body physiologically, including your drive to breathe. And that's why when people die of opioid overdoses, in most cases, it's their respiratory drive that was suppressed to such a degree that they simply stopped breathing. And as you know, if you stop breathing, that's not very compatible with life. So whenever we're looking at a patient's opioid dosing, or we're looking at possibly increasing or starting a medication, we're always very cautious in that regard, particularly for patients that, let's say, have sleep apnea or COPD or breathing issues. It's something we really have to think about and be careful about if we want to avoid problems with that patient. Opioids can also be very constipating and can also affect patients' mood. So there are some times with patients who are taking opioids on a long-term basis where either through our suggestion or on their own accord want to taper off or discontinue the medications. And for patients who are able to tolerate that from a pain perspective, a lot of those patients will subsequently note that their mood gets much better. And they didn't really realize how much their mood was affected by opioids when they were taking them until those medications are removed. And certainly it can affect things like fatigue. There's another feature of opioids that I think most people are not aware of, and that's hyperalgesia. So most of us think of opioids as being helpful for pain, at least in the acute setting, sometimes in the chronic setting. Something that most people aren't aware of is that sometimes opioids can behave in a kind of a paradoxical manner, and that it can make your pain worse. And this is particularly as the dose gets higher and higher. So when you have someone that's, let's say, taking more than 60, 80, or 100 milligrams a day of an oral opioid, they can start to experience hyperalgesia, and it may not always be clear to them what's happening. They just notice that they're hurting and they're having pain, and if anything, they want to take more medication. But sometimes what these patients will find, and we'll be working closely with them, is if we can dial back the doses, a lot of times they'll find their pain actually improves. Another important area to be aware of when it comes to opioids, and a lot of patients become aware of this if, let's say, they're seeing us and we're being asked to perhaps take over their medication or help manage it, all of the paperwork and regulations involved. There's a lot of state and federal involvement, as well as the medical board, and a lot of regulation around opioids that is separate and distinct from other prescription medications. And this is sometimes be a little overwhelming for patients in terms of all the monitoring, frequent visits, urine testing, paperwork, education, all those kind of things. And then for some patients, a barrier to taking chronic opioids can be alcohol consumption or other kinds of substance use. Let's talk a little bit about acute versus chronic pain, and we've touched on this a little bit already. So acute pain, I think most people are familiar with this. Let's say you break your ankle, or you get in a car accident, or you have some type of defined injury or event. Usually the cause is pretty well known. You get an x-ray, you see the broken bone, it's very clear what's going on. Whereas in chronic pain, sometimes it can be a little more difficult. Even if we know, let's say this is low back pain, the question can still be, well, what in the low back is causing the pain? And we need to really answer that question before we can come up with a good plan. As I tell a lot of patients, before we can have a good treatment, we have to have a good diagnosis. And this chart here also kind of echoes that as well. Acute pain, the cause is generally known. Chronic pain, the cause is sometimes unknown. The duration of pain is usually less with acute pain. Chronic pain can be months to years. And then the treatment approach is also going to have to be different. Acute pain, often it might be casting, it might be surgery, splinting, and patients generally have a sense that this experience is going to wrap up within days to weeks to months. But chronic pain can be very different than that. And a lot of times it requires a bit of a mindset shift of, is this something we can cure, or is it something that we're really going to need to focusing on treating and managing? And the analogies that I'll sometimes use with patients is diabetes is one analogy. It's overall pretty rare that for a patient who's diagnosed with diabetes that is cured. I mean, it can happen sometimes if, let's say, they're a type 2 diabetic and they lose a ton of weight. It may be that their diabetes status goes away for a period of time, if not indefinitely. But in general, it's really more a matter of managing, and that might be medications, it might be lifestyle changes, exercise, etc. The other analogy that I'll often use with patients, I don't know if any of you ever heard of the concept of phantom limb pain. So let's say someone has a bad injury to their foot, and whatever happened with it, it might have been a trauma, or maybe they had a circulation issue and they had a non-healing ulcer there for months to years, and they had really bad pain in that foot for months to years. And then let's say their condition progresses to the point where eventually that foot requires an amputation. And it's removed. For a lot of those patients, they'll still have foot pain, right? And it's not that this part of their leg hurts, their foot hurts and they do not have a foot anymore. And that's because the pain signals are not always just in the area where you're feeling it, but they can be stored in your central nervous system. That may be your brain or your spinal cord, and can basically play like a recording or a video in your central nervous system, even if the structure is not there anymore. And that's often why when we're prescribing medications for chronic pain, instead of opioids, we might be using seizure medications, or we might be using medications within the antidepressant class that can be helpful for pain, where we're treating the central nervous system part of that pain. And it can be a very complex experience in terms of the physical and mental aspects of it. As I mentioned earlier, stacking different treatments together is often a good way to go in the setting of chronic pain. And that may be physical modalities, physical therapy, osteopathic manipulation, acupuncture, medications, injections, etc., lifestyle changes, finding multiple things that help and kind of stacking those things together. And that requires a lot of work on our part, the care team, and usually requires a lot of work on the patient's part as well. So let's talk a little bit about spine pain. And before we do that, I'm going to talk a little bit about anatomy. So most people are familiar with the fact that there's different sections of the spine. So we have, let's see if this has a laser on it here. Maybe not. But I'm fortunately pretty tall, so we can just use me as the pointer. So we have the cervical spine, thoracic spine, and lumbar spine. And these have similarities, but they also have unique features that we need to account for when we're treating those areas, because each of those areas has different kinds of pain issues, and some of them have similar, and when we're deciding about medications, injections, and things like that, we need to factor that in. So this is an x-ray here of the cervical spine or neck. You can see the vertebrae there and all the different components of each vertebrae. And those are things we're looking at. We're looking at a patient's MRI. What feature that may be unique to that patient, where it might be a certain joint or certain disc in their neck, and then allows us to focus our treatment. The mid-back area basically runs from the base of the neck into about the middle of the trunk, basically between the shoulder blades and extending a little bit above and below that. We don't tend to see as much disc issues usually in the mid-back because the rib cage acts as a fantastic back brace. It's kind of a built-in excellent back brace. So the discs there are usually relatively stable. We do see a lot of muscular pain in the mid-back, and I'll talk in a little bit about how we end up treating that. The lumbar spine has a lot of different structures in it that can cause pain. There's discs, there's nerve roots where that disc can herniate and push on. There's the facet joints that I'll talk about in a little bit, which are a very common area for wear and tear arthritis, and we treat that in a very different manner. And for every area of the spine, there's multiple layers. And I said in the beginning, you know, if Toyota made the human body, there'd be a recall on the spine. There's a lot of problem-prone areas, and it's just a very common area for people to have pain. So there's, you know, skin, there's fascial layers, muscle, there's discs, which can be either direct or indirect pain, right? You can have a tear in a disc, and then the disc itself may hurt because its structure was altered. Or if that disc herniates, it can start pushing on something else, and now that other structure, like a nerve root, starts letting you know about it. And then there's many different joints in the spine, and those can develop wear and tear and arthritis and have pain. The spinal cord, as you can imagine, is a vital structure, right? Starting from the brainstem and going down. So if someone's seeing us for neck pain, when we're looking at their imaging and examining them, one of the first things we always want to look at is making sure they have good room for their spinal cord and nothing's going on there that could compromise their function below that in terms of strength, sensation, walking, etc. We do see a lot of muscle pain in our practice, and there's a variety of causes from that: overuse, posture, perhaps deconditioning. Usually by the time patients have seen us, they've already usually done some physical modalities, whether that's physical therapy, stretching, they're trying to get out and walk, things like that. And we do have procedures we can do for that, namely trigger point injections, which we do quite a bit of, which are muscle injections. I was talking a little earlier about how discs can be affected both within the disc and then also pushing out on other structures. Facet joints are a very, very common area that we treat very frequently. And I think even with the best of pictures, it can be a little difficult to see what I'm talking about. So I might just walk around a little bit here. So I think when most people think about the spine, right, most people kind of think about vertebra and discs, right? This is what most people think of when they think about the spine. Each vertebrae, I think, is useful to think of as a three-legged stool. And this is the big leg here, right, where the vertebra meets the disc. However, there's two other important legs of that stool, and that's where each vertebrae comes together and meets in the back of the spine. And this is an area a lot of people really aren't that familiar with. And these are called the facet joints. And you can see each vertebra comes together, and this is another important area for stability. And particularly in the low back at the very base of the spine, you can almost think of this as like the shocks and suspension of your back. And so when you get enough miles on the odometer, particularly in patients who already maybe have a little bit of genetic predisposition for wear and tear arthritis, it's very, very common that these lowest two sets of facet joints will develop arthritis and may develop pain. In the neck, it tends to be more in the mid-neck. I think a lot of this is from the leverage of the head rotating and moving back and forth. And it's often these joints in this area that will develop notable arthritis. And we can usually see that pretty easily on their x-rays or on their MRIs. So a lot of this I've already talked about. Usually patients come to us referred from their primary care physician. We really want to take a very thorough history and exam. If they don't already have imaging studies, we're going to order appropriate imaging studies to get a kind of a deep look at their spine and see what may be going on, or if it's a joint, imaging of that joint. And then we'll try to come up with some systematic treatment recommendations, trying to start with least invasive and least costly things first, and then kind of building from there. And then I think follow-up is vitally important. You know, if we try plan A and plan A is working, great. then let's just establish how long plan A tends to work and see you back at that interval, and maybe we'll just keep repeating plan A. If plan A doesn't work, then we need to see you back and come up with other ideas. We need to reassess our diagnosis. Did we have the right diagnosis to start out with or not? If we did, then maybe we need to try a different treatment angle. I think we've kind of covered these items already. Let's move forward. So we did touch a little bit earlier on osteopathic manipulative therapy, which I do in my practice. And there are some similarities to chiropractic, and there's been a lot of studies on hands-on and spinal manipulation showing different mechanisms of action. And it's very common. You know, about 1/3 of patients that have low back pain at some point will try some type of hands-on treatment, whether that's physical therapy or chiropractic or osteopathic manipulation. This is actually a picture from one of the lectures I did with some of my colleagues from medical school, where we were lecturing at a national meeting on osteopathic manipulation. And this is an example of a pretty gentle treatment. We're actually here using the patient's legs as gentle levers to affect change in their pelvis and low back. And it can be surprisingly helpful. Instead of having to lay them on their side and kind of crunch and lean your body weight on the patient, here you're just using a very specific and gentle range of motion with their legs to get things moving in the low back area. In terms of medications, and we've touched on some of this already, usually by the time patients have seen us, they've already tried some over-the-counter medications, whether it's anti-inflammatories, Tylenol, etc. A lot of patients will ask about muscle relaxant medications, particularly if they're having muscle pain. I think something to be aware of that vast majority of muscle relaxant medications are really just sedatives in some way, shape, or form. Most of them are not doing anything magical where they're going to go into muscles and make those muscle fibers relax. Most muscle relaxant prescription medications are muscle relaxants as much as Budweiser or Cabernet Sauvignon would be a muscle relaxant. You know, they have some type of central nervous system depressant quality, which just kind of tones down the volume and signals and makes the muscles then perhaps relax a little bit. I'm not saying that they're necessarily a terrible idea, and for certain patients they can be appropriate, but it's just something I think to be aware of. And if I have patients that are, let's say, working in a manufacturing setting or they're a commercial driver, that's something we want to be careful about, right? Because just like you wouldn't want to drink a beer and go drive a big rig, you don't necessarily want to take a lot of the muscle relaxants and do that either, or use your lawnmower or weed whacker for that matter either. Anticonvulsants, that's the formal name for a class of medications that are the seizure medications. I don't know, some of you may have heard of medications like gabapentin, which also goes by the name Neurontin, pregabalin, which is Lyrica. There's a few other ones. Those are the ones that are most commonly used for pain. And even though they're in that class of seizure medications, the ones I've mentioned are almost never used for seizures. And they're almost always used for pain applications. And no single medication is right for every patient, but in some patients, those can be really helpful. There are some antidepressants that can also be helpful for pain. Medications like duloxetine, which is Cymbalta, is a good example of that. And a lot of times patients will kind of look at me a little bit funny when I mention that we may be thinking about an antidepressant, because maybe they think I'm telling them that their pain is in their head or something like that. And I'm clear with them that I'm not a psychiatrist. I'm not trying to treat their mood. I'm actually prescribing this medication to them specifically for their pain. For example, duloxetine, which is Cymbalta, although its pharmacologic family is an antidepressant, it's been studied extensively for pain. It's FDA approved for chronic low back pain. It's FDA approved for chronic arthritis pain, for diabetic neuropathy, etc. So it's been studied outside of just the mood or psychiatry realm. We've already kind of talked about opioids, and in some patients they can be appropriate. And again, it's one of those things that sometimes you're stacking with other things. They might be on 2 non-opioid medications. They might be doing water-based exercise. They might be taking an opioid. They might be getting injections a couple times a year. And we're kind of stacking all that together to try to make an impact for them. We talked a little bit earlier, I have LDN there, low-dose naltrexone. That's something we mainly use for fibromyalgia, although there are some potential applications in other chronic pain settings. And we've been trialing that as well. And it's safe enough that it's something that's very safe to try with the vast majority of patients. And apart from the cost, doesn't have a lot of downside usually. And then some of you may be aware that New Hampshire has a medical cannabis program. And this is something that's been in place for a few years now. And there are set state-regulated dispensaries around the state. Patients will come to see us usually if they've tried other things for their chronic pain. They'll need a medical certification from a physician or a nurse practitioner, and then they can then get their card from the state and take that to a dispensary. And for some patients, it can be helpful. I want to leave some time for questions, so I'm going to go a little bit more quickly through these last few slides. We're going to talk about some of the injections that we do. This is not a picture of our operating room here, but I think I found this on Google Images, but it's just a good example of what the procedure suite can look like. This machine here is called a fluoroscope. It's basically a portable low-dose radiation X-ray, and it's also known as a C-arm because it's got this big arm shaped like a C. Part of it goes above the patient, part of it below. And we can take pictures in real time of their spine. I usually have a foot pedal I can use where I can take images, I can adjust the angle, take another image, and then once we're placing a needle, I can place the needle, take a picture, move the needle, take a picture, and we can guide it exactly where we want to go in the spine. I think we have a couple example pictures here of that. Let's buzz ahead here. All right, so this are X-ray pictures or fluoroscopic pictures when we're doing something like an epidural injection. So let's just show an example here. So let's grab the spine. So this actually here is a spinal needle. And let's say, for example, a patient's been having back pain, they have a disc herniation that we've identified. What we'll look for on their imaging is good openings to be able to safely get in their spine to perform an injection that may help their pain and deliver medication. So for example, if this was a patient, we'd say, boy, it looks like they have some great spots in these areas where we might be able to get in their spine and do a safe and effective injection. They'll be face down on a procedure table. We'll bring in our X-ray machine. This is what it will look like to us, and you can kind of see this picture here. Kind of shows that same thing kind of enlarged a bit. And we'll numb up the skin. Of course, we've already cleaned the skin off and draped it and all that. And then we'll sequentially advance the needle under X-ray guidance to our final destination. Once we're there, we'll usually inject a little bit of contrast dye, which is a liquid that shows up under X-ray. You can see that here. I don't know if you can see, it almost looks like ink that's kind of layering here in the spine. That's what it looks like to us. And what's nice about it is I'll usually have it on a little bit of extension tubing. I'll be injecting the contrast dye and I'll keep my foot on the pedal and I can watch where it's spreading, which is particularly useful, and I can make sure it's going where I want it to, and if not, we can adjust the needle if needed. So let's look at a couple other ones. So that would be the circumstance, let's say someone has a herniated disc, some type of pinched nerve phenomenon. We'll end up doing that kind of injection. We talked earlier about facet joints, and here are some common referral patterns of some of those different small joints across the back of the spine. And sometimes it can mimic a pinched nerve type pain, right? Sometimes a patient will come in and say, hey, my back's hurting me, it's shooting down my leg. We'll get an MRI and there's no disc herniation. And we'll say, this is kind of curious. We're expecting to see a disc herniation, expecting to see a pinched nerve, and we don't. And then we look a little more closely at their MRI and we see this very, irritated, swollen, arthritic looking facet joint, and they're getting a referred pain phenomenon. And this study actually was done, they took some unsuspecting and financially compromised medical students. This was, I think, 20 or 30 years ago. And they said, hey, you guys want to sign up for this study where we need to look at referral patterns from facet joints? And under X-ray, they placed needles in their facet joints and they pressurized them. So they kept adding liquid to their facet joints until they had pain, and then they asked them to draw where they were feeling the pain. And yes, most of the pain they feel is at the spine, but as you can see, a lot of these test subjects are reporting pain that extended beyond the spine. So that's why I always need to keep an open mind when patients come in reporting certain pain patterns, that it might be one thing that may be the most common, but it might be a few other things as well, potentially. A unique feature of treating facet joint pain is that we'll often do diagnostic injections first. So this is not an injection with steroid, but just purely with numbing medication to confirm that the facet joint is the problem. And this is a picture here from doing blocks where we're going next to those facet joints where the little nerves tend to run, and we're applying a little bit of numbing. And then if those are positive, in other words, if I numb just their facet joints and nothing else, and their pain goes from a 9, let's say, to a 1 or 2 or a 0, that makes us pretty confident we found the problem. there's a procedure called radiofrequency ablation where at a later date, let's say a couple weeks later, we'll place a special needle right next to that pain sensing nerve next to their facet joints, and we'll apply a little heat to that area, and we'll actually zap that pain sensing nerve. It uses technology similar to microwave technology in that the needle itself is not directly getting hot, but it's using radio frequency current to vibrate the molecules in the tissue around the tip of the needle. And that's kind of how a microwave works, where it vibrates molecules, the vibration creates heat, and the heat cooks the food. In this case, we're cooking a small area of tissue about the size of a small marble in a very controlled manner. And actually, I brought along a radiofrequency needle, if anyone's interested, and I'll show you how we would do this. I know looking at slides gets old, so I brought some show and tell items as well. So this is an example of one of the radiofrequency needles. This is a 17 gauge needle. You know, it looks pretty beefy, but be assured we do a lot of numbing before I use this needle. And you can see, like, for example, here's a facet joint here. The pain sensing nerve that supplies this joint runs in this little bony groove. Hopefully most people can see that. There's a little bony groove here. So off of this big spinal nerve, we're not looking to burn this one, you need this nerve. There's a little thin thread-like nerve, and it runs in this groove, and then it wraps around to this joint and this joint. So we basically try to head it off at the pass. So once we've confirmed the facet joint is the problem, I'll place a needle there, and then once I'm happy with the needle location, I'll remove, let me show you, I'll remove the core of the needle. So the needle will stay in place. We'll remove the core of the needle, okay? And then we have our radio frequency machine. It kind of looks like that ultrasound machine, but a little bit different. And it has special probes that connect with a wire that will go down in this needle, protrude about 2 millimeters from the tip, and then we'll burn that small area of tissue. Those procedures usually take about 30 to 60 minutes, depending on how many areas we're treating, you know, et cetera. So I think it's sometimes helpful to kind of see the equipment we're working with and what we're talking about. Let's see if this wants to wake up. There we go. Nerve stimulation is another potential procedure. I do not do spinal cord stimulation here. I was trained in that when I was at Mayo Clinic. It's a relatively uncommon indication. You know, it's relatively rare that patients require this or are appropriate for it. And what I was finding in my first year or two is we weren't really doing it that often. I think for any procedure you're doing, you want to be doing it all the time, right? You never want to get rusty with a given procedure. So that's something that we usually refer out. Although I recently went to a conference on peripheral nerve stimulation, which is something that's a little less invasive, and that may be something that we'll be offering over the next year. We have to do a little bit more logistics and training and things like that. But we'll be able to use what we already have for tools in terms of the ultrasound machine and x-ray guidance. And for some patients, that may be very helpful. It's a temporary stimulator opposed to spinal cord stimulation, which is a permanent. Ultrasound-guided injections, we talked a little bit about that earlier. A lot of times, patient may be sent to me for low back pain, and we come to find out it might be hip arthritis that's actually causing their pain. So we have ways of injecting those areas precisely. We can use x-ray guidance, but oftentimes the ultrasound machine is nice because we have it right there in the office and we can treat them right in the same visit, which a lot of patients really appreciate. These are actually example pictures here from an ultrasound injection. This would be for a hip injection. So this major bone, a lot of you may be aware, is the femur, right? It runs from the knee to the hip. And the last segment of the femur, right before it gets to the hip joint, is what's called the femoral neck and the femoral head. So this is the ball, and then the socket sits over here. So I have my ultrasound probe sitting like this, right over the upper part of the patient's thigh, and this is what it looks like to me. I can see the skin, I can see the muscle layers, the tendons, I can see the bone, and then their joint capsule runs right over here and then goes down to about here. So as long as I get through the joint capsule, I can inject within the joint. Another nice feature of ultrasound is that it can detect motion. So for example, in this patient's case, they have an artery and vein sitting right here in front of their hip joint. Now I could run a needle through those and it probably wouldn't really cause them any harm, but if I can avoid it, I'd rather avoid it. So in this case, hopefully this will wake back up. I'm able to see that and identify it by turning on the color mapping on the ultrasound machine, and then I kind of ran over the top to avoid those. I don't know if you can see the shadow here of my needle running from the skin, popping underneath the capsule, and then if you watch this area, that's where the steroid, you see the capsule lifted up off of the bone here as I toggle back and forth. That's as the medication starts infusing into their hip joint. So it's a great tool to have right in the office. So good news. Last slide. So in summary, I think a thorough evaluation is extremely important. No two chronic pain patients are exactly the similar, right? Everyone has their unique features, and so we usually spend a lot of time in that first visit going through history, exam, what's been tried before, and trying to find any areas of opportunity that we might be able to improve their situation. We always want to exclude dangerous or urgent issues right out of the gate. Make sure there's nothing that needs to go see the surgeon, hopefully. We like to start with least invasive options. As I mentioned several times, we always are usually looking to use multiple treatment options and kind of stacking areas of benefit to get maximum relief. We definitely have a team approach. I'm very fortunate. I think my nurse, Mark, has been with me 6 years. My medical assistant, Bree, which some of you may have met, she's been with me 3 or 4 years. And frankly, they know what I'm thinking before I say it, which is wonderful. So they can read my mind, and that's valuable. The other thing that I think is really important is they know the patients, and the patients know them. And I think, although there's some places you can go for care where you're really more of a patient of that department rather than a particular physician or person, I think there is a lot of value of having that continuity. You know, there's a lot of patients where when I just see their name or face, my brain immediately starts going through their chart. You know, it's in my head, and I kind of know a lot of details. I can still reference their chart, but I think having that kind of knowledge of the patient, and also from the patient's perspective, knowing what to expect, having a team they trust, I think is really important. We try to do a lot of patient education and set appropriate expectations, because as I mentioned earlier, we're not always going to be able to cure that specific situation or area of pain, but hopefully we can find things that provide meaningful benefit for the patient. And then I think following up with the patient is very, very important. Sarah wasn't able to be here tonight. I think there was an issue with her dog sitter or something, so she had to run back home. But some of you may have met her. She's my nurse practitioner. She's been working with me about 2 years. She's fantastic. She's extremely thorough and really does a lot of great deep dives with patients, and I think she's been a great asset to the practice. And if you've already been to our practice or are coming in the future, you'll meet Mark and Bree, who are also part of our team, who are fantastic as well. What kind of questions do you folks have?
Do most of our basic insurances cover?
Typically, yeah. Yeah, so spine injections are very, very common. So most of the common and typical spine injections that we do, and for that matter, most of the medications we use, are covered. I did mention radiofrequency ablation, and we certainly use that a lot in the spine. We also sometimes use that for joints as well, particularly the knee, and that can be a great option for, let's say, someone has bone-on-bone knee arthritis, and they're either too many medical problems for a knee replacement or something like that. Unfortunately, that procedure has gotten more restricted by insurance companies over the last few years, although straight Medicare still covers it, which is good. For most of the things we do, though, for example, like Botox for migraines, that's an FDA-approved procedure, so it's very hard for insurance companies to wriggle out of not paying for that. Yeah, so most of these things are covered by insurance, yeah. Yes, sir.
When you do prescribe opioids, do you provide Narcan or naloxone?
Usually, yes. Yeah. Particularly, it's a little dose dependent. So let's say I'm prescribing a patient, there's a medication called tramadol, which is a fairly lightweight opioid, and they're taking 1 or 2 a day. For all intents and purposes, that patient probably doesn't need Narcan. However, if there's a patient taking oxycodone and they're taking 50, 60 milligrams or more a day, that patient should have it, and their family members or who's ever living in the same domicile as them should know how to use it. Because let's say by accident they take too much, or what would be a more common scenario, let's say they're sick, right? And the 10 milligrams of oxycodone they take, which normally doesn't faze them at all, may really put them down for the count if they have the flu or something like that. And now they can't wake them up. They need to have something right there to be able to reverse that medication. It may be too late for an ambulance to come to serve that purpose. So yes, that is part of our patient education, and we'll often send those prescriptions. And the regulations around that have gotten better and better, where now we can send in a prescription with a lot of refills, and it will just always basically be there for patients at the pharmacy, typically speaking, when they need it.
Any other questions?
What is the general way that you have patients come off opioids rather than just you help them this week and not next week?
Yeah, so, particularly if they're taking relatively high doses, although really, even if it's been mild to moderate doses over long periods of time, the time factor is probably more important. It's usually important to stop slowly, because otherwise it can create a lot of unnecessary unpleasantness. Very early in the talk, we were talking about dependence and the physiologic aspects of opioids. So if you've been on them a long time, even if the doses aren't really high, but especially if the doses are high, the withdrawal issues can be quite significant and potentially prolonged. So the only reason we would typically stop a patient kind of abruptly would be relatively unusual circumstances. Like, let's say we discovered a patient was selling their medication, or they were abusing it, or they're supposed to be taking a really high dose, and then they get their scheduled urine testing and there's no medication in their system. Well, we're probably going to stop the medication because we've been prescribing it, but apparently they're not taking it, and we're worried about where it's ending up. So it's relatively rare, though, that we would stop it abruptly, and usually we'll try to step it down. I mean, most aggressive would be over days, but usually it's weeks to months. Yes, sir.
You mentioned a relatively long time and high doses. Can you just give us an idea of what those times are and doses are?
If you've been taking opioids longer than a month or two, you're probably at a significant chance you're going to have some withdrawal. And then the dosing, it's somewhat individual, and it's also very dependent on the particular medication, right? So 50 milligrams of tramadol is totally different than 50 milligrams of oxycodone. But I think it's safe to say if you're taking multiple doses per day, regardless of strength, and you're doing that for more than a month or two, coming off that medication is probably going to have to be done in a stepwise and controlled manner. And I think a really important part of that is having that conversation with the patient to find out what they're comfortable with, because some patients want to just rip off the Band-Aid. They're like, I want to do this as quickly as possible, even if I have some withdrawal symptoms, and we may end up prescribing them some medications to help with those withdrawal symptoms. Whereas other patients say, I've been on this for 10 years. I'm really nervous about changing my dose. Can we do this over 3 months or something like that? And then that's likely, as long as there's been no compliance issues, there haven't been any legal issues or anything like that, there's no reason to be, I think, overly aggressive with it. Any other questions?
Yes.
For some people whose bones do not show up very well on X-ray, I've forgotten the name of the machine, but it's something like that technology better to see conditions?
You mean like the ultrasound?
The ultrasound, thank you.
I'm mainly using the ultrasound in my practice for guiding needles. There are times you can use it for diagnosis. Usually, let's say we're talking about spine pain, for example. Ultrasound is usually not that great for spine diagnosis because it's pretty depth dependent. It's sending out a sound wave. It has to bounce and then come back and then be interpreted. So when you're, let's say, looking at someone's carpal tunnel, it's beautiful. I mean, you can see wonderful detail because it's going down about 1 centimeter and coming back. When you're talking about the spine, it's got to go through skin and fascia and muscle. And then once you get to bone, it's not going to penetrate at all. So usually if x-rays aren't showing what we want to see in the spine, then usually we're jumping to a CAT scan or an MRI or something like that. You know, each of these tools, just like any other tool out there in the world, has things that it's really good at and things that it's not quite as good at. So it's up to us to kind of sort that out for a given patient, given diagnosis, like what's the best tool to get the job done for this patient for a safe and effective procedure. And then you folks are also welcome if you want, because it seems like we're pretty much wrapping up. You know, if you want to come and look at some of the things up here, you're welcome to do that. I have the ultrasound machine. If someone wants to kind of see how that works, I can show you what it looks like on my wrist or something like that. Does anyone else have any other questions? All right. Yeah, go ahead, ma'am.
Some years ago, I've got some herniated discs in my neck, and I visited with you some years ago, and you sent me to Dr. Houston, who I absolutely love, and she's retired. Are you telling us that you are doing a similar gentle manipulation?
So her primary technique, Dr. Houston's a chiropractor. She uses the handheld instrument. I don't use that in my practice because that's a more chiropractic specific technique, but I do gentle hands-on manipulation. So there's some similarities, but also a lot of differences as well.
Because I am terrified to go to somebody who might be.
You're not looking at, you don't want that.
Okay.
And it can be hard to find folks that do hands-on work in the spine where they're using really gentle techniques. Because the gentle techniques, frankly, are a lot slower, right? When I'm doing osteopathic manipulation, I mean, those are often 30 or 40-minute slots. And, you know, admittedly, those are money losers, right? The hospital is absolutely losing money with my time on those, but it's a necessary service and we offer it because it's important. But if I was in private practice, that would be very difficult. You know, it'd be hard to keep the lights on in a scenario like that. And I think that's why the rack 'em crack 'em techniques are pretty quick. And for some patients, you know, they're good, right? Some patients really like those techniques. So I'm not knocking that, and I'm definitely not knocking chiropractors because a lot of patients see chiropractors and they were happy with their care and they're doing well. But there's no one treatment that works well for all patients. And it can be difficult to find folks. I know in this area, for patients that we're seeing her, trying to find something similar within a geographic radius is a challenge. It's a challenge, yeah. All right, well, we're at our hour, so that's pretty good. We got in the lecture and all the questions. We're under an hour, not too bad. I appreciate everyone coming out and taking time out of your evening. Appreciate it.